Hello, everyone. Welcome. We're just going to give people a few moments to join. And as you're joining, if you could just introduce yourself in the chat box with your name and your organization and the country, that would be great. And we'll get started in just a few moments here. All right, we'll give people just a few more moments to transition calls, but if you have joined us already, please go ahead and introduce yourself in the chat box with your name and your organization and the country that you're from, and we'll get started in just a minute here. And Casey, if we could actually go to the next slide, or the previous slide. There we go. Just a reminder, everyone, that we do have French translation available for this webinar. To access the French translation, you can go to the globe icon at the bottom of your screen and choose the French option there. And then you also, as you can see here in that option, want to click on mute original audio so that you're not hearing both the English version and the French version. For people who want to listen to the webinar in English, you can just continue as you are. You don't need to click any buttons. Great. Well, maybe we can go ahead and get started. And I know we'll have a few more people join us as we move forward here. So we can go ahead to the next slide. And again, as a reminder for everyone, if you haven't joined us before, welcome everyone. Casey, could you go to the next slide, please? There we go. This is a webinar in a series of webinars in the West Africa Regional PrEP Learning Network. We are part of the Choice project focused on introducing and supporting the introduction of oral PrEP across sub-Saharan Africa. And in the Choice project, we have a particular focus on West Africa, really working in support of policymakers and implementers to introduce oral PrEP. To learn more about the Choice Project or this series of webinars, you can go to the website here on PrEP Watch, and there you can find all of the recordings and materials from previous sessions. And you can also sign up for updates and information on upcoming webinars using the link that you see on the screen. And we will be sharing these slides, so all of this will be available to you following the webinar. Great, next slide, please. As we've gone through this series of webinars, we've been coming back to this framework to help us think about what are we actually talking about? And how does this fit into the broader picture of oral PrEP introduction? So our previous sessions have focused on topics related to planning and budgeting. In December, we went through the PrEP tool that supports target setting and costing. Earlier in the series, we went through how to set guidelines for oral PrEP. We went through planning for oral PrEP. We've also talked about, kind of gone over to the other side of this framework and talked about demand creation and delivery models for PrEP. And today we're going to focus in on models for provider training for PrEP and learn from several partners who have either developed tools or curricula for provider training or who have implemented provider training programs. And yes, Katie, thank you for the reminder. For those who are just joining us, please introduce yourselves in the chat with your name and your organization and the country that you're from. And there is also French interpretation available at the bottom of your screen if you click on the globe icon. So today we will be going through a series of presentations, and we really welcome questions or reflections or responses in the chat box. The first agenda item will be a quick overview of different models and considerations for PrEP provider training. I will be taking us through that. My name is Neeraj Bavaraju. I'm with the Choice Project. Then I will hand it off to Jason Reed from JPIGO, who will introduce the JPIGO WHO PrEP eLearning course and tool and resource. Then we will pause for Q&A. I will then hand it over to Michael Odo from FHI 360, who will take us through his experiences implementing oral PrEP training in Ghana. We will again pause for some Q&A, and then we'll hear from our colleagues Robin Dayton, also from FHI 360, Regeru and Joseph from LVCT Health in Kenya and PZAT in Zimbabwe on different considerations for provider training, particularly to deliver services to key populations and to adolescent girls and young women. We'll have some more time for Q&A, and then we'll wrap up at the end. And you can see here our list of presenters. So without further ado, I think we'll go ahead and get started. Just a reminder, if you're looking for the French interpretation, you can click on the globe at the bottom of the screen, select the French option, and just make sure that you hit mute original audio so that you're not hearing both audio streams. And please go ahead and introduce yourself in the chat as you're joining. Well, great. Well, I will provide a quick overview of different considerations for healthcare provider training, just to serve as background as we go into the more in-depth presentations. And this is a set of findings really from across the Choice Project partners, including LVCT Health in Kenya, PZAT in Zimbabwe, WITS RHI in South Africa. So we can go ahead to the next slide. What we've found as we really learn from the experiences with oral PrEP and provider training for oral PrEP is that it's important to provide training not just to healthcare providers, although that in and of itself is a big cohort. So important to include a range of providers in PrEP training, including doctors, nurses, community health workers, pharmacists, and private sector providers. That's kind of one big group. We've also found that it's very helpful, especially in the initial stages, to include policymakers and other key stakeholders in PrEP training programs, including national and subnational stakeholders, such as policymakers, regulators, and supply chain managers. Also, M&E staff can be very helpful as well, just to build everyone's understanding of PrEP. We've also seen PrEP be integrated in different ways in training. So the one that's most likely to happen is in-service training here in the middle. That's training of healthcare professionals who are already employed on a new product or approach. So I'm sure that this is how many of your programs have introduced PrEP. The other thing that we've seen as PrEP has rolled out in different countries is that it's really important here to the right to include PrEP and support for PrEP on an ongoing basis and ongoing supervision and mentorship. That this really helps providers take up new products and services and ensures that they're being delivered in a high quality way. The last thing I'll highlight is on the left of the slide, thinking in the long term about integrating new products like oral PrEP into pre-service training is also important. Across the countries that have introduced PrEP, this has not been the first step, but is often something that is important in the longer term, especially as staff turns over. So actually building it into the base of healthcare providers in pre-service training is an important step, typically a little bit in the future as PrEP is being scaled up. Next slide, please. What we've seen, especially in-service training, is that there's several different models of how countries have approached provider training for PrEP. And you'll see these different approaches on the right-hand side here, and I'll go through them in a moment. But what we've seen across different countries is that there's really no one-size-fits-all approach to provider training. Many programs use a combination of approaches, and the right approach really depends on the local context. And each model has benefits and challenges. So I'll go through these models on the next slide with a brief introduction to what we've found and seen in practice. So the first dimension that different countries have considered is whether to do a cascade model of training where there are master trainers who are trained on PrEP, and then the trainings are cascaded to others within their regions or their facilities. Often we refer to this the train-the-trainer model. And the benefits of this are really that it enables a much broader reach. The challenges are that it requires a kind of cadre of highly effective and credible trainers to be able to do this throughout the system, which can be a little challenging. And it does, as a result, require significant oversight and quality checks because there are so many different people providing training throughout the system. The other approach that some countries have used is a highly centralized model where either Ministry of Health officials or key partners are implementing provider training for everyone. Of course, the benefits of this model are that it supports greater consistency of messaging, quality, oversight, and it enables providers providing PrEP across facilities to actually build networks and connections with one another. The challenges are that this may limit the number of providers who are actually able to receive training, or that the training sessions might be so large that they're not actually effective. So we can certainly see some trade-offs between these two models. The other dimension that we've seen different countries and programs consider is whether to do trainings at a facility, so have a facility-based training, or to hold trainings off-site, or increasingly online, especially during COVID. So I would say that, again, each of these comes with trade-offs, and we've seen from the experiences that a facility-based training is generally seen as more cost-effective and offers less interruption of service delivery. But it means that the training itself may be interrupted because people are still at the facility and may be interrupted. It also means that it limits the opportunity for cross-facility networking. Off-site trainings, typically something like a day or 2 days or 3 days, where people can really focus on learning about PrEP. It enables cross-facility networking, and it really enables deep training and focus on PrEP. The challenges are that this often requires additional costs, and can be more disruptive for ongoing service delivery. And then finally, a model that we will hear about a lot is an online model, or an online and in-person hybrid model. So that's what we will be hearing about in our upcoming presentations. An online resource can be a cost and time effective way to reach a broad range of providers. But there are some challenges in that it may not support deeper learning, enable kind of joint problem solving, especially on complex concepts. And so we'll see how some of our presenters have overcome this challenge with a hybrid model coming up in just a moment. Next slide, please. And the last thing I'll share is that really across different oral PrEP training, curriculum, and resources, we've seen 4 major areas that are covered in the trainings. So the first is just the basic product attributes, including clinical background, target population, product use considerations and side effects, as well as kind of putting PrEP in the context of broader HIV prevention. The second, and this takes up significant time in a number of the trainings, is really working with providers on how to do client counseling, risk screening, often with a particular focus on specific populations, such as adolescent girls and young women, or key populations. And we'll also hear about those 2 topics from our presenters today. And then finally, the trainings typically cover some information on supply chain management and monitoring and evaluation, really especially to support providers as they're actually implementing and tracking PrEP delivery. So let me pause there. That was a quick overview of things to consider in provider training. And I will now hand it over to my colleague, Jason Reed, to provide a quick overview of the WHO implementation tool for PrEP. And then we will pause for Q&A. But before I do that, just a reminder to please introduce yourself in the chat as you join the webinar. And then also please add any questions that you have to the webinar, to the chat box, and we will pull those up for our presenters. Thank you. And Jason, over to you.
Thanks, Nirja, and good morning, good afternoon, colleagues. It's a pleasure to join the webinar. I'm going to present a very brief summary of one of the online PrEP training tools, and follow up to what Nirja just presented about online training as an option. So WHO and JPIGO began partnering about 3 or 4 years ago to take the WHO implementation tool for PrEP of HIV infection, which was a paper-based resource that WHO developed to help implementers with PrEP programming, and to translate that into an actual training curriculum that providers could access online, to try to help standardize the information that providers were receiving as part of their training, and also to expand access to that training curriculum. So next slide. So what is the PrEP e-learning tool for clinicians? I mentioned just a little bit in the prior slide. It's a tool for doctors and nurses primarily, who are new to HIV PrEP, but wish to begin prescribing PrEP to their clients to reduce the client's HIV risk. As a training tool online, it is self-paced, meaning that the entire training need not be completed all at one time. Someone can go in and complete as much as they wish, stop and come back at later dates repeatedly until the course has been finished. It's interactive, so there's lots of sessions where active participation is required to verify comprehension of key learning points. It's internet-based, but you need not have internet access the entire time because it's set up to be quote unquote asynchronous, which means you can access the course when you have internet and download parts of it, and then reconnect to the internet at a later time. And most importantly, it's free to anyone that wants to take it. It's aligned specifically, like I said, to the WHO implementation tool, which is important because PEPFAR requires that all of their PrEP implementers program HIV PrEP in accordance with WHO guidance. This particular training only deals with one of the modules in the WHO tool, and that's the clinical module. We divided the content into 4 lessons, and each of those lessons takes about 45 minutes to an hour to complete. So if you did sit down one day and went through the entire course from beginning to end, you can estimate that it would probably take 3.5 to 4 hours. But most people take it one lesson at a time, so that it's just 45 minutes to an hour on any given day. And then it's designed, as most online trainings are, to be interactive, to have visuals that are engaging. It has narration, so that the information that you see on the screen is accompanied by additional explanation by a narrator. And you can access the course not just from a computer or a laptop, but also from a smartphone or a tablet, as long as it has internet access and audio. Next screen. So in terms of how the online training is structured, if you access the system, you're first presented with a course overview, and then initially there was a pre-test, which we have since removed. Then you find each of the 4 lessons. The first lesson addresses suitability or eligibility for PrEP and how to identify who is an eligible candidate for PrEP. The second lesson talks about starting and managing a PrEP clients. The third lesson talks about special situations that may arise in PrEP clients as they start and continue PrEP. And then the last lesson, lesson 4, talks about counseling messages about effectiveness and safety, and specifically how providers have an important role in avoiding stigma. At the end of lesson 4, there's a post-test just to verify comprehension of the information. And then if the post-test is passed with a score of 80% or higher, there's a certificate of completion that can be downloaded and printed. Each of these lessons, 1 through 4, includes technical content, knowledge checks along the way, and at each end of each lesson, there's a quiz, just to make sure that the information is registering as the course is completed. Next slide. So for the first lesson, like I said, addresses suitability or eligibility for PrEP. Next slide. The screen looks like this. We're just showing you how different screenshots so that you could see quickly the kinds of visuals that would be shown. Next slide. And I'll just go through these really quickly. These are all just screenshots, so you can see if you access the course exactly the kinds of information that you would see. Again, there is a narrator also that would be helping you navigate your way through by speaking to each of these issues. Next slide. And you can basically just run through these next slides one after the other in rapid succession. They're just intended to show the content that a typical user would see. And you can kind of see the interactive sessions where it asks you to do things, to click through different pieces. There are also case studies throughout the lesson so that we can verify knowledge using actual examples of PrEP clients from the field. Each of the lessons has learning objectives so that you know from the beginning what would be expected. There are a lot of drag and drop exercises as part of the interactions. Next. So all of these slides are basically just to show you that if you were to access the course, the kinds of information that you would see, the visuals. Unfortunately, you can't hear the narration in the PowerPoint, but all of the slides have the narration, the interactive sessions, the quizzes, the knowledge checks, etc. Okay, and then holding here for just a second. The online training is also accompanied by an app that you can use from Android and Apple iPhones or tablets. And so the app basically includes the WHO implementation tool, but in this way it would be sort of a pocket resource since you could access it from your phone. And the app also includes a creatinine clearance calculator, which is often helpful as you do the online training. Next slide. More visuals of the app on the iPhone. And then the final slide is I wanted to verify or clarify that the current version of the training has been updated. So it not only includes daily oral PrEP, but also event-driven PrEP for MSM populations. We do have an online option for clinicians to provide feedback. And we have done facilitations of cohorts of trainers going through the course at any given time. So that there are WhatsApp groups for exchange of information punctuated by Zoom webinars to try to get at that more collegial feel of classroom learning that might otherwise be lost when doing only an online training. The English version of the course is available at this website, www.hivoralprep.org. A Spanish version is also available on the PAHO, the Pan American Health Organization virtual campus. And there is a French version that's currently being produced that will be available by the end of March of this year.
Great, thank you, Jason. Does anyone have any questions or reflections that they wanted to share, either in the chat or you can go ahead and unmute yourself and just speak to the group? And if there aren't any thoughts or questions for now, we can go ahead to our next speaker to see how this was actually implemented in practice with a hybrid online and in-person model. So let me just check to see any questions about the previous presentations. If not, we'll go ahead and move on. Okay. Well, then I will pass it on to you, Michael, to share your experiences with PrEP provider training. Oh, Michael, you may be on mute.
Hello, hello.
Yes, there we go.
Great, thank you very much. Thanks so much, Niraja and Jason, for the excellent presentation. Apologies for that little breach. My internet turned off temporarily. So warm greetings from Liberia, and good morning, afternoon, and evening, depending on where you are on the planet. It's my great opportunity doing this presentation on the behalf of colleagues in Ghana, Trudy, and colleagues in DC, Danielle, Chris, and Tiffany. Thanks a lot, colleagues at Choice, for the opportunity to do the presentation of our humble effort supporting the Ghana Health Service, the National AIDS Control Program, the Ghana AIDS Commission, in their effort translating policy to practice for oral PrEP in Ghana. Next slide, please. Maybe I want to start from what we had in mind ahead of the training. And the objective was to create a national pool of master trainers that would be available for the Ministry of Health, implementing partners, irrespective of the area of coverage, and then also for the community-based organizations and other organizations that focus on high-risk group. And I'm happy colleagues from WAF, West African AIDS Foundation, who work with KPs are also in this training. Our objective was to create this national pool that could cascade step-down training, whether at central facility or for sustained hands-on mentorship, supervision for oral PrEP in the various models that Niraja presented first. And wanted to achieve the best of results, not minding the COVID restrictions that were available at that time. So necessarily, we had some good time ahead of the training, working with the Oral PrEP Implementation Committee, a broad spectrum of stakeholders working on the HIV space in Ghana. We developed an implementation guide which was aligned with the existing policy framework contained in the HIV/AIDS treatment guideline for Ghana. And then, of course, initially focused our efforts where the PEPFAR IPs were allocated to work in Ghana. And then we adapted the existing PEPFAR PrEP training curriculum, the ICAP training of trainers and participant manual. And then what Jason just presented was extremely very, very helpful. And then we did as much as possible to feature local context and realities, describing local supply chain processes and M&E. Next slide, please. So part of the task of the Ghana National PrEP Implementation Committee was to design a roadmap. And the roadmap had some rigid time points. Unfortunately, at that time, the time point for kickstarting the training and ultimately implementing oral PrEP happened in the midst of COVID. But the fact that that enabling environment was already there by the NACP was very, very helpful. So the training was anticipated for June. We lost a few weeks and ultimately did it in July. Next slide, please. So we had two arms, hybrid, virtual, and in-person training. And we had persons allocated to play this responsibility. And there were clear rule definitions of who will do what and who will do what, both virtual and in person. And at some point, we combined both of them, simultaneous virtual and in-person training. So I had the humble role of playing the lead facilitation virtually from Liberia. I had colleagues supporting from DC, Danielle and Chris. And then we had in-person facilitators who were present in the conference room, the hotel venue that was hired for the purpose. Trudy leading the team with the FHI 360 IT team, as well as colleagues at Equip Health Ghana. And then all the participants had to complete the online JPIGO training rated by WHO, which Jason just presented. And then the trainer's responsibility, as mentioned before, was to adapt the existing PEPFAR and WHO PrEP trainings to fit into the Ghana context, in addition to developing role plays, group work sessions that align with the learning objective. Next slide, please. Now, in the hybrid, the in-person we had, as I mentioned, the Equip Health colleagues who are the KPI-SR for capacity building and mentorship, and then the EPIC field staff, as well as the FHI 360 IT team, and their responsibilities included coordinating the role plays, providing feedback, manage the breakouts and plenary session, manage the virtual platform, including usage, muting, and unmuting functions. And these were very, very critical because when at any point in time that these were missed, you hear a lot of echoes that distract both segments of the training, in person and virtual. And then, of course, they were also helpful in supporting the necessary logistics for COVID-19 prevention. Next slide, please. Now, another aspect of the preparation was in the careful selection of the participants. This was led by the NACP and the Ghana AIDS Commission, but then it was deliberate to ensure national spread as well as need, especially people who are going to be organizations and persons who are going to be working on the allocated geographical areas in Ghana for PrEP implementation. So the National AIDS Control Program, Ghana Health Service, JSI, the implementing partner for the Care Continent Project in Ghana, Ghana AIDS Commission, and then the regional HIV coordinators who are actually representatives of the National AIDS Control Program in the various regions of the country. And then the EPIC implementing partners, Equip Health, WAF, and then the WAPCAS. Next slide. So we boiled the training process to both the before the workshop, during the workshop, and after the workshop. All of these segments were very, very important to get our objectives. So before the workshop, criteria for selecting the participants was carefully walked through with the Oral PrEP National Implementation Committee. So the selected persons had previous capacity in ART training and facilitation, just to give us assurance of eligibility to be a master trainer within the Ghana space. And then, of course, some of them were also currently supporting or implementing an HIV program, whether hands-on or at policy management level. And then there was a requirement for every participant to have completed the online self-paced training. And then the training slides and manuals, case scenarios, and the references were shared in advance to participants to study and then to come to the training with questions. Secondly, next slide, please. Part of the preparation that was very key was the preparation of the venue. The Tomrec Hotel in East Legon, Accra, where the in-person and conference component of the training was to take place. The FHI 360 Accra team had to work with the hotel to have giant screen that really brings the virtual facilitators to appear as though they are within the training hall and to ensure that level of smart coordination in presenting and asking questions, movement of microphones, and then very importantly, ensuring COVID-19 prevention preparedness, in ensuring physical distancing as appropriate, hand sanitizers at entry and on every table, and then the use of facial mask. And the duration of the training was really a full day. Next slide, please. Then in the main workshop management, the design had to be deliberate to ensure active engagement. So several facilitation techniques were used, presenting from the slides and pausing at every point now and again to take questions and to provide answers, from the plenary. And then interactive sessions were provoked, brainstorming session, group conversations and reflections, case studies that were contextualized for the environment the participants were very familiar with, and then role play with lead role from the participants. And then again, facilitation practice for participants, since the ultimate objective was to make them master trainers. Next slide, please. For the training itself, it was begun by opening remarks by the NACP program manager, who himself also joined virtually. Then there was a pre-test, and then a review of workshop rules, expectations, and objectives, and then the delivery of the training modules and the mannerism that were going to go, including the role plays, the clinical scenarios, and mock facilitation, were all discussed at the beginning of the training. And then the post-test for participants. Participants who are going to be eligible to become master trainers needed to have above 80. And then the participant evaluation was also done at the end of the training. Next slide, please. So for training evaluation, the objective of the pre-test was essentially having provided the online self-paced training platform for all the participants, and then sending all of the present training materials ahead the training. The objective of the pre-test was, one, to know how much of knowledge had been acquired before the training, and then to bench that on how much training would have been gotten after the training. So the participants scored on the average 76% on the pre-test and 83.5% on the post-test. 5 participants scored below 80%, and most of them were drawn from the policy level participants, and they were referred for follow-up training. For the training evaluation itself, 85% of the participants scored the training as excellent in general conduct, facilitation, technical content, and management by the facilitators. And then 20% scored the training as good for both pre-workshop preparation, the travel logistics, and the venue. Post-workshop support, next slide. Post-workshop rollout trainings were provided to selected private hospitals and public health facilities by the equipped master trainers. And then the staff from Liberia and Washington, D.C. have continued to provide mentorship meetings directly with the team, equipped team in Accra, as well as responding to ongoing questions that come from the National Implementation Committee. And I think the last slide, factors to consider. There should be strategic selection of participants, and we're careful about this, understanding the peculiarity of implementing oral PrEP within a country with several ERT clinics, and so assure personal interest of the participants, ensure a pre-workshop evaluation and preparation, especially with the online self-paced training platform, send training plan, curriculum, and materials in advance, and then set up a social media group in our instance, WhatsApp platform created by Trudy, our colleague in Ghana, was extremely very helpful in coordinating the participants, troubleshooting uncertainties and questions, especially arising from the use of the self-paced training. And then assure steady internet connectivity. The pre-test technology was very helpful. Then good audio is necessary, so virtual participants can hear the face-to-face participants, and the FHI360 IT colleagues on ground in Accra were helpful in guaranteeing this. Next slide. I think in overall, we think a hybrid model of virtual and in-person training is possible to effectively engage participants and communicate knowledge. And in-person step-down trainings are necessary at facility level, especially for a program like oral PrEP. Finally, I'd like to talk a little quickly, a few bullets on challenges. Next slide. So in preparing for a mixed virtual and in-person training, it's key to prepare for the risk of poor internet connectivity, repeated echo from the floor of the in-person arm of the training, especially when microphones are not muted. And then, of course, side conversations could arise sometimes when the virtual facilitators are presenting. And then trainees in the virtual arm, there were some trainees who couldn't come to the floor of the training. They joined virtually. For those trainees, they couldn't participate in the various clinical scenarios that were deliberately designed to stimulate conversations and learning. Thank you very much. I'll be happy to take questions.
Thank you, Michael. I see one question in the chat for now, which is Katie asking if the training curriculum that you developed is publicly available or is something that you could share.
Yes, it's publicly available. We basically adapted the PEFA supported an ICAP-led training manual for both participants and facilitators. Yes, it's publicly available and we can share.
Great. Does anyone else have any questions for Michael or any reflections that they would want to share from their own training experiences or using a hybrid virtual and in-person model? Please feel free to raise your hand or just go ahead and unmute yourself and share with the group if you have anything to share.
Are there other people on the call or in your countries where the provider training has been done or a training of trainers has been done through a mixed method like this of in-person and virtual? Or other TOT approaches that people have implemented for PrEP?
Hello, may I contribute?
Sure.
So hello, everyone. This is Regeru from Kenya. So just as recently as last month in Kenya, due to the ongoing COVID-19 pandemic, we had to rethink around how to do training for providers around work that we're doing to integrate PrEP services into family planning services. So what we did is actually carry out our training workshop via what we called a virtual hybrid, in that for one or two of the days, the facilitation was entirely virtual, as was the attendance of participants. But on the final day, participants, as divided into their facilities, each had their own day where, as a facility team, they met in person, but the facilitation from our end occurred virtually. And that worked very well because it involved practical exercises which could really only be done with the team together in person, and with good coordination on our end to make sure they had all the materials and job aids required. We were able to pull it off and it was a success. Thank you, and over.
Great.
Thank
Thanks
you, Regeru. Does anyone else want to share on the use of a virtual model or a hybrid model for training? Okay. Well, please just raise your hands or send a note in the chat if you would like to share or if you have any other questions. And if not, thank you. Oh, please go ahead.
Hi, Niraja. This is Patrick Ikane from Nigeria.
Hello, Patrick.
I think it's exciting. A lot of us have done so many virtual trainings, but uniquely what Liberia, what they presented, what Mike has presented, is well documented. It shows pretest outcomes and all that. I think this is a lesson for many of us, and I want to say a big thank you to the team for coming up to also share this in a wide group like this. We've done PrEP trainings, we've done a lot of PrEP demand creation, even virtually, and use some online platforms to do that. But I want to say thank you because this is unique, because it documented the entire process and it's lessons that we can learn across countries. Thank you.
Wonderful. Thank you, Patrick, and thank you, Michael. And please, if anyone else has questions for or thoughts for Michael, please share them in the chat. In the interim, we will go ahead now and transition to 3 presenters who are going to share about their insights and lessons learned for particular considerations for provider training to deliver PrEP services to key populations. And Robin will be taking us through a short presentation on key populations and considerations for provider training. And then that will be followed by a short presentation on key considerations for provider training for PrEP services for AGYW. So for now, I will pass it on to Robin.
Great, thank you so much. And I'm really happy to be here with everyone on this historic day in the US to talk about something that I hope we all end up talking about more and more going forward. And that is offering health services that are appropriate, friendly, welcoming to everyone, and especially groups that have been traditionally most vulnerable and marginalized. And I know this might seem like a bit of a jump, moving from a focus on PrEP back to a focus on broader health services. But of course, PrEP delivery happens within a context. And so if a larger health system or a facility is not welcoming to the people who most need PrEP, then it's going to be a struggle for even the most knowledgeable healthcare worker to provide that service. And given that the key populations most affected by HIV, so gay men and other men who have sex with men, sex workers, people who inject drugs, and transgender people, given that these folks are some of those that can benefit the most from PrEP, I'm going to be talking about a curriculum that's designed to improve providers' ability to give that appropriate KP-friendly care generally, as well as by offering some specific services that address essential needs. So next slide. So this is just a quick outline of what I'm going to be presenting. I'm going to start by going over the rationale, why we developed this training material. I'm going to talk through the content and its delivery, share a few examples of impact, and then some of our lessons learned. And I did want to note this is available to be downloaded. The hyperlink is there. This was developed under the Linkages project, the predecessor to the EPIC project, and IntraHealth International played a key role in developing this curriculum. They were a partner under Linkages. Next slide. So thinking about why this training or others like it are needed, I wanted to share a few data points with you all. So the first, this comes from a study in 2020. In Accra, Ghana, 3.3% of men who have sex with men said that they were refused a health service because somebody at a facility believed that they had sex with men. In Senegal in 2017, 22% of female sex workers, 18% of men who had sex with men who were surveyed reported that they actually felt afraid to even seek a healthcare service. And then in 2019, this was a study across Kenya, Malawi, and South Africa, 29% of men who have sex with men and transgender women reported avoiding seeking healthcare services because somebody at that facility might discover that they had sex with other men. So I think what this really clearly illustrates is that pervasive stigma and discrimination towards key populations, including, but not limited, by healthcare workers, really has to be addressed to get people in the door and make sure that they get the healthcare services that they need. And one of the ways to do this is to increase the knowledge and skills, change the attitudes of healthcare workers so that they can identify and address stigma and discrimination against key populations at their facilities and acknowledge the role that they can play as institutional change agents. Next slide. So how does Health for All, keep going forward, should say contents overview. Okay, perfect. So how does Health for All try to create this change among healthcare workers? You can see the outline of the contents here. It is a 3.5-day training. The agenda for days 1 and 2 is at right. And it's divided into 4 modules. So the first module really focuses on why we need to provide HIV services to key population members specifically, explaining that we cannot have epidemic control without meeting key populations members' needs. It also describes who key population members are, with a focus on understanding gender identity and sexual orientation, and the issues that they may face related to substance use, violence, and other human rights violations. Module 2 focuses on beliefs that healthcare care workers may have about key populations, trying to understand where those beliefs come from and how their beliefs may be impacting their service provision. Module 3 is on clinical standards, and I'm going to review those in details next. And then module 4 really asks healthcare workers to make a plan and a commitment to being those change agents going forward. Next slide. So taking just a closer look at module 3 that covers appropriate services, the training reviews the top 10 clinical standards of care for key populations, and it does that across all 4 of the groups that I mentioned before. And I just want to point out 3 things here, and then you can certainly review these or the full training should you desire to do so. So the first is that PrEP is certainly a part of this. It's number 3 here on this list. So this could be a natural place if you felt the need to address stigma and discrimination broadly, but you wanted to really focus in on PrEP. There would be a natural place to expand training or add new tools to complement this training and really move forward in PrEP implementation. Second, the list here addresses some of the key concerns of key population members. So if you look at numbers 9 and 10, gender-based violence and mental health care are often raised as some of the most pressing service needs that key population members face. And this is above and beyond HIV prevention care and treatment for some people. So another thing to consider in a facility offering PrEP is that you may also want to really enhance service provision in other areas that clients prioritize in order to encourage more people to come. And then finally, this module that focuses on clinical standards of care does describe a bit more detail on the needs of specific populations. You can see that at right. And that body of knowledge has continued to grow since this curriculum came out. So I will talk about some supplemental materials available just at the end of this short presentation. Next slide. So in terms of delivery, this really differed place to place depending on local needs, but generally speaking, we did have different groups of workers that were trained together. So nurses, doctors, receptionists, lab staff, janitorial staff. This was meant to make sure that the full clinic was welcoming or the full facility was welcoming, and to break down hierarchies between these groups so that they could really work together and learn from each other. It's practical and adaptable. I'm going to talk more through some examples of adaptations in just a moment. It encourages self-reflection, again, especially on attitudes, and creates a safe place for that reflection. It addresses root causes of stigma, including rigid gender norms. So it's really a natural link to trainings on gender-based violence. And it creates a space for interaction. So key population members are engaged in different ways. They can be facilitators. They can play different roles in planning, which we'll talk through in the lessons learned. And then in each of these trainings, there was a panel of KP members who come together to share their needs and concerns and answer participant questions. And then as a final point here, the training, when it's talking about next steps, recommends continued refresher training, data review, policy development, other things to really change structurally and over the longer term. A lot of what was discussed at the beginning of this full webinar that allows for continued and sustained change. Next slide. So local needs really dictated delivery and content. And I wanted to just show some examples here. So you can see from the initial implementation, this has been given in a wide variety of contexts. This is not actually a comprehensive list, but it just gives you a sense of the countries that we implemented in as this tool or as this training was developed. and each location could adapt as they needed to. So for example, in Cambodia, they chose to add a day of content on gender-based violence, and then that made the training 4.5 days instead of 3.5. You can also see that the populations that were going to be relevant to the country or to the program dictated what was covered. So in this slide, you see at the top right, this is in Khmer, it's from Cambodia. It compares HIV prevalence rates among female entertainment workers, men who have sex with men, people who inject drugs, and transgender people. Other countries only worked on the issues faced by men who have sex with men and female sex workers, or some other combination of key populations, just depending again on the focus of their program. The Health for All curriculum, it was also adopted at the national level in some countries. So you can see at left, this is a national training in Indonesia. It includes elements of Health for All that they combined with locally used trainings in order to have a national training used across providers. Next slide. So I do want to share some examples of impact. We do not have a formal evaluation of the training, but in each setting, we had different examples, both of process and then some changes in terms of clinical uptake that I wanted to share. These are a few examples from Kenya and Cambodia. So in Kenya, all of the trained facilities developed stigma and discrimination policies and hung them up so that the clientele understood what it was that could be expected from the providers, what they could do if they didn't receive the treatment that they should expect. This one was from Gold Star Kenya. Also in Kenya, advocacy forums such as county KP technical working groups and county advocacy subcommittees came together after the training when new cases of discrimination came up. So one of the ways they wanted to implement their plan going forward was to use existing groups to discuss cases as they occurred and then plan mitigation measures according to the issues being brought to them. In Cambodia, they began a patient service feedback system that was established at ARV clinics so that they could continually monitor how patients perceived the services. And then finally, again, while there was not a formal evaluation across the settings where we've used the training, we have seen at some facilities increased attendance and then improved service quality in terms of anecdotal reports. Next slide. So what did we learn? Some of those learnings are reflected in the document that you see here that you're welcome to read if you want to learn more. But essentially, and again, I think a lot of this reflects what was shared earlier, you know, making a plan with government stakeholders from the beginning so that you're aligned to local policies, to the national aid strategy, so that there's clear buy-in from the very top for those healthcare workers being trained. At the same time, working with key population members so that they really share what their central needs and concerns are and that those can be addressed really clearly. We learned that some clinical topics benefit from additional training. And this has actually been really positive because what we see is providers becoming more competent, feeling more comfortable working with key populations and then expressing a desire to go deeper. We definitely have seen the value of continued monitoring, and I'm going to talk through in the next slide a system in use for that monitoring, just present a bit of that data to you. And this is hugely important for indicating where continued training or mentoring would have the greatest impact. The fourth bullet here, that the stigma impacting health service uptake isn't limited to what happens in the facility. So this training is only about changing what's happening in the facility, but we know, for example, key population members who've been arrested are less likely to seek health services. So we know we can't make all the changes necessary if we only work in the facility. And if you remember from the rationale that I presented at the start, some KP members really fear even coming to a facility to see what the treatment is like. So there needs to be a way to let key population members know what's happened at a facility so that they know that they can expect better treatment there. And then finally, you know, as I said from the beginning, there is, you know, we knew from the start how important mental health was to key population members. One of the lessons learned that we have from this work is just how important mental health is also for providers. So there is a lot of secondary stigma. Family members rejecting somebody because they provide services to KP members, someone being kicked out of their religious community. So mental health services can be an important piece as well for the providers trained. Next slide. So I want to just talk through, as part of the lessons learned, I mentioned how important continued monitoring is. Many of the facilities that we worked in used tablet-based systems after the training so that patients could indicate how the services they received went. You can see from this screen here, this can be filled out by clients and providers. It is most often filled out by clients. And the clients note the services they came in for so that you're getting really specific feedback on the different services offered. And of course, PrEP could be one of those services. And if you can advance the slide, it should come to a second screen. So this was one of the most important questions asked on that survey, which is quite short and is also developed for people to use, including in low literacy contexts. But one of the most important questions was whether the client would recommend this service to a friend. And of course, this information can be useful to individual providers, especially if we know, okay, people said they would not recommend the PrEP services at this facility, or they would not recommend, the HIV testing services at this facility. Individual providers then can be retrained as necessary. It can also help facilities overall look at how they're doing and how they compare to others who they might want to learn from if they have that kind of relationship across facilities. And if this information is shared with key population community members, they have the sense of where to expect quality of care. Again, because it is so important to remove the barrier that comes from anticipated stigma. Okay, next slide. And just as a final point, one of the great things about implementing Health for All in so many places and over so much time is that we've really had the opportunity to see spaces where additional, deeper clinical training is needed. So we do have some materials that can be used in conjunction with Health for All to improve understanding of gender-based violence, for example, improve education on family planning for female sex workers, including education that occurs by peers, and then some additional information on transgender programming. We also have materials that help to engage other sectors, including law enforcement, to address some of the barriers to care that occur even before someone comes into a clinical facility. So I just want to close by saying that implementing these trainings and some of the others that have been described here, using these materials together with Health for All, can really deepen the clinical services available and create an enabling environment that encourages people to come in for a range of services, including PrEP. So final slide. Thank you so much to everybody for your time, and I look forward to answering any questions that might come up.
Great. Thank you, Robin. Any questions for Robin? Please feel free to type them into the chat or unmute yourself.
Would it be okay if I just commented on the comment about the law enforcement training? Wasn't exactly a question,
yes, go
but
ahead.
Yeah, I would just say that, because use of post-exposure prophylaxis can indicate a need for PrEP or the potential need for PrEP, it's really helpful to think about connecting the PrEP service or the PrEP training to those who are working with survivors of sexual assault. And that does include the law enforcement folks. So we really stress when we train law enforcement the importance of how they interact with key populations, but also the importance of quick referral to clinical services. And so that could just be another opportunity to also make the link to PrEP services so that they're aware of that option as well.
Wonderful. Thank you so much, Robin. Well, why don't we move forward to our next presentation, but if people have questions or reflections, please add them to the chat and we will come back to them after this next presentation. So the next presentation is going to share with us experiences and resources for supporting providers to deliver PrEP services to adolescent girls and young women specifically. So I will pass it on to my colleagues, Rogeru and Joseph.
Good morning, good afternoon, or good evening, everyone. Niraja, may I confirm that I can be heard?
Yes, we can hear you very well. Thank you.
Okay, thank you. Apologies for any background noise that may occur. So I would like to take the next few minutes to talk about a provider training package as developed under the Options Consortium for the effective delivery of oral pre-exposure prophylaxis for adolescent girls and young women. Next slide, please. So we've heard a lot about established training packages and curricula when it comes to oral PrEP. However, as we know, in sub-Saharan Africa, there is a disproportionate burden of prevalence as well as new HIV infections amongst adolescent girls and young women. Therefore, this training package was developed under the Options Consortium to address a gap in that no existing PrEP training materials had been specifically designed for the provision of PrEP to adolescent girls and young women. So the training package was developed to build the capacity of frontline providers to deliver quality, client-centered oral PrEP and HIV prevention services to AGYW. So as we'll see shortly, there was a clinical component, but the focus of this training package was very much around the quote unquote soft skills and special considerations that come into play when it comes to initiation and management of oral PrEP services for AGYW. So these training models complement already existing training curricula internationally and within countries for their established PrEP curricula. And it's also highly adaptable, and I will aim to give you examples of that as we go along. So just to mention, looking at the statistics there, that we know that adolescent girls and young women are 2 to 3 times more likely to be infected with HIV compared to their male peers. And beyond the biological factors that contribute to this, there are a lot of harmful social and cultural norms that come into play. Providers are not exempt from these. So it's really a training package geared towards addressing and unpacking those in order that healthcare providers realize that ultimately their role is to ensure that AGYW are informed about all the HIV prevention choices they have available to them, and to enable them to start and continue on oral PrEP if that is what is most appropriate for them. Next slide. So the training objectives of the package are for healthcare providers to understand the key components of youth-friendly sexual reproductive health and combination HIV prevention service delivery, including oral PrEP services. So youth-friendly is a buzzword that is thrown around all health service areas. And often what you find is that youth-friendly healthcare providers may typically think that means we need to have a dedicated room that is specifically just for young people and adolescents, when in reality, in resource-limited settings, that is often not possible. So a big part of the package is really unpacking what youth-friendly, youth-responsive, and youth-sensitive services means, and realizing that the key principles of those can be readily applied in any context without sort of needing to have a separate room, for example. Second objective is to understand which AGYW are most likely to benefit from oral PrEP, for healthcare providers to be familiar with specific country guidelines and protocols, to identify entry points and opportunities for discussing and offering oral PrEP. That is especially important as we continue to advance the drive for integrated HIV prevention and sexual and reproductive health services, where we are finding that family planning service delivery points are a key entry point for HIV prevention services, including oral PrEP. Understanding the management of oral PrEP for adolescent girls and young women, identifying ways to provide youth-friendly oral PrEP adherence and counseling support, understanding the range of specific knowledge, attitudes, and skills required to provide oral PrEP to AGYW, and raising awareness of how one's own values may influence communication with clients, both positively and negatively. Next slide. Next, thank you. So the training package is split up into modules that each have a very specific focus, and these are available on PrEPWatch, and each of these modules has their own slide deck. So module 1 is an introduction to oral PrEP, and this is really the main clinical component of this training, whereas the rest covers the other objectives that I've just read through. So the basics of oral PrEP are covered, and this includes what PrEP is, contraindications to its use, baseline assessments that are necessary at the point of initiation, etc. And in that, the specific points that are geared towards common questions that are likely to come up when providers are dealing with their clients, such as how to talk about the effectiveness of oral PrEP and the differences between PrEP, PEP, and ART. PrEP is then discussed in the context of the whole portfolio of HIV combination prevention. And then, of course, when adapted to a country-specific context, everything that I've mentioned thus far for Module 1 should be set within country-specific guidelines. So, for example, different countries may have different guidelines when it comes to the lead-in time when someone has started on PrEP before you'd say they're fully protected, and also about how long they may need to continue PrEP when they decide to stop. So all these specific country considerations need to be included as you deliver this in your context. Module 2 is about the provision of oral PrEP to AGYW. So the importance of PrEP for AGYW is discussed, and that goes over the epidemiology we've just touched on briefly, as well as the drivers for new HIV infections among adolescents and young people, particularly adolescent girls and young women, particularly those related to harmful social and cultural norms. Unpacking what adolescent and youth friendly mean, and unpacking personal views and values about PrEP and AGYW. And within this module, there are a lot of practical exercise that rely on great interactivity between participants and openness to really explore all the values and opinions that may exist around this. Again, with the aim of getting to the end point that no matter what one's own opinions may be, at the end, the responsibility of a healthcare provider is to provide the best possible services to the AGYW to fully protect themselves from HIV. Module 3 is about factors for consideration around combination prevention and other related services, and the evidence and lessons learned that have been learned around PrEP provision for AGYW. Module 4 is about the process of initiating AGYW on PrEP. So first reaching them through demand creation, then talking about risk assessments and how these need to be handled sensitively in this particular population, how to address myths, misconceptions, and fears, and knowing what the likely ones are to occur among AGYW, factors influencing decisions to initiate or stay on PrEP, and key issues to discuss with AGYW. Module 5 then naturally progresses to monitoring, follow-up, and adherence. So how to promote the same amongst AGYW. So there's special advice there geared around AGYW, and again, frequently asked questions that may come up as they go along their PrEP journey. Module 6 is about formulating action plans that lead on from the training. And Module 7 fits into Module 1. When we did it in Kenya, we've tied this into Module 1, where it goes into even more consideration around the clinical components of oral PrEP services. So in Kenya, we included this module as part of the first module that we dealt with our participants. Next slide. So an example here of what is very common throughout the training package, which is exercises to carry out with participants. This is an example that is taken from the module unpacking what youth-friendly services means. So the first part around that is an exercise around appreciating the differences between adolescent girls and young women and assessing what stereotypes and assumptions healthcare providers may have. So these questions are posed to the participants, and they can either be done in a plenary format or a group work format or a buzzing in pairs format, whichever format you feel is most likely to yield openness from your participants. Next slide. So key learnings from our implementation of the options provided training package have been that it is crucial to adapt it to the local context, that there should definitely be a focus on integrating it both in terms of what the existing training materials are, but also into the larger framework that exists within your country for the provision of HIV and sexual and reproductive health services that are youth-friendly, youth-sensitive, and youth-responsive. It's very important that at the time you go in to deliver it, you ensure that all the information, especially clinical information, is up to date. And hopefully it's delivered in a context where there is follow-up supervision and coaching. So the point is made that everything that has been taught will be updated, particularly with regard to new HIV prevention products as and when they become available. And just to highlight the point that it's well and good to be able to train providers on the same, but the follow-up support and supervision as they go about actually implementing what they've learned is critical. And this really now falls onto national and subnational level health managers to follow through on the implementation following this kind of specifically tailored training to address a particular gap. Next slide. In conclusion on my end, before I hand over to Joseph from Zimbabwe, just to highlight how we've used it in Kenya. So the modules from the options provider training package covering the provision of youth-friendly, youth-sensitive, and youth-responsive services has contributed to this content as covered in Kenya's National PrEP training curriculum. And we've used the provided training package directly as it is to train 30 healthcare providers and 3 sub-county AIDS STI coordinators in Kiambu County. And most recently, we've used it in the virtual hybrid format that I mentioned recently to develop content, particularly on the PrEP side, for training that we've done for integration of PrEP and FP services to 50 family planning providers, HDC providers, PrEP providers across 3 healthcare facilities in Nairobi, along with 17 sub-county health managers. Thank you, and I'll now hand over to Joseph to highlight their application of the package in Zimbabwe.
Thank you, Regeru, and hello, everyone. I'll be very brief and share our experiences from Zimbabwe. So as a country, we have had a standard comprehensive and integrated HIV prevention care and treatment training package, which has evolved over time. Depending on new imaging strategies and guidelines. Over the last 3 or 4 years, this package has been delivered through blended learning platforms. So this includes a combination of in-person sessions as well as online sessions, and in some instances where connectivity is a challenge, distance learning models are being implemented. So when PrEP was included in our national guidelines, we then went through a process of adopting the training package from options, and PrEP, the training is delivered as part of the blended learning package that I highlighted earlier on. But because we also want to reach more health workers, more facilities in the country, there's also a parallel process of delivering the same package as a standalone training, especially for facilities that have already been covered with the other components of the blended learning package. So the adolescent girls and young women modules were integrated into the standard training package after a review by a team of trainers and also the National PrEP Technical Working Group. And after refining the package, we then went through a process of training national trainers across the 10 provinces in the country, and these provincial trainers have then been cascading the trainings to the rest of the districts and facilities in their provinces. So to date, we have district coverage of over 90%, in which we have trained people using this package.
Thank you very much.
We continue to refine the package with new evidence and integrate with any other processes that are ongoing in the country with the guidance of the National PrEP Technical Working Group. Thank you, Kate. Back to you.
Great, thank you. And Rogero and Joseph, if I could ask you to respond to a question in the chat. How did you deliver the distance learning modules? And given that we're actually coming up on time, I might ask you to just type your response into the chat, if that's okay, in response to that question, just so that we can wrap up here. So if we could go ahead to the next slide, and Rogero or Joseph, if you could type a response to that question about the distance learning modules into the chat, that would be great. But just so that we wrap up here on time, a reminder to everyone that our next session will be on February 17th on PrEP and intimate partner violence, and integrating intimate partner violence screening and support into PrEP services. That will be on February 17th. Casey has just shared the link to sign up for updates and calendar invites to future sessions. And then our other sessions beyond February are undetermined for now. So we actually would like to do a quick survey with you, which will come up momentarily, to ask you what topics you're most interested in, or what topics would be most helpful for you. And if there are other topics that are not listed here that you would really like us to cover in these webinars, please add them to the chat box. That would be incredibly helpful. We want to make sure that these webinars are useful for you. And then finally, as people are filling out the survey, we also wanted to get your feedback on this overall series of webinars. So we will be sharing via email after this webinar a broader survey to ask you for your input. So you can see the links in the chat. We would really appreciate it. That survey should hopefully only take about 5 minutes, but it'll help us make sure that we're actually meeting your needs, addressing the topics that are of most interest to you, and are structuring these webinars in a way that is helpful. So please take a moment to respond to the survey, both the one that's on the screen and the one that Casey has just shared in the chat box, which is a slightly longer version.
And votes are still rolling into the poll, so I'm just going to give it another 30 seconds or so before I shut the poll.
Wonderful. And thank you so much, everyone, for joining us today. If you have any further questions or thoughts about the webinar series, please feel free to reach out to us, and we will be sharing the materials from this webinar in the email and online, and we look forward to getting your further feedback on this webinar series. Thank you very much. Oh, and I see we have some questions coming in. Rogeru and Joseph, if you are still on and can respond to some of these questions, people can feel free to drop, but Rogeru and Joseph, if I still have you, there's a few questions in the chat, and it would be great if you could respond either just by unmuting yourself and sharing, or typing into the chat box here.
Hello, so I've seen two questions in the chat, one about how we tackle the distance learning, and then about the cost of PrEP. So I'm not sure that I've correctly understood the first question about how we covered the distance learning, but if it's just about how we were able to do it in a virtual hybrid format, it was straightforward to do it with regard to clinical content, doing it in a similar way to as we've all joined in today. However, when it came to practical group exercises, such as the ones around unpacking people's opinions and values, etc., then the poll function, for example, was very useful, where we posed certain questions to participants, got them to vote on where their response lay, and then had people from either side contribute in, be it by unmuting themselves or via the chat. And to speak to the cost of PrEP, in Kenya, as per our public health government facilities, PrEP is provided at no cost to the client. Thank you.
Great, thank you, everyone. So with that, we will close for today. Please feel free to let us know what you think about the webinar series via the survey, and also follow up with any questions using our emails. Thank you so much.